Susan Armiger, President and CEO of Catalight. Okay, please. So, Susan, welcome back to Brussels. I know you've been here for quite some time at the previous juncture. You are from New Zealand, but you've been based in the US for an impressive period, which led you to receive one of the top Women in Health Innovation Awards late last year. So congratulations for that. And you're also a global pioneer of value-based care. And that proposition aims to reimagine healthcare by focusing on quality, outcomes, and access. And I want to ask you at the outset about your theory of change, because you are clearly dealing with the health systems that have been shaped over the years, in a somewhat different fashion, and you are putting forward the proposition that they should be outcome-based, that they should be looking at value first, and that they should have patient at the center, which paradoxically enough they often don't have, right? So what is your take on how to go about this?
As in a theory of change?
As a theory of change,
okay.
Yes, exactly.
I think my perspective on that's changed over the years, and I would say that I think about that old English idiom, needs must. I don't know if people are familiar with it, meaning when there's a need, you must do something, right? If the need is great enough. And I think I see that happening, and I think people come along that journey in different ways. So when there is a really big need, there are people who are somewhat proactive about that need, or they act first, but they act because they must. And then I think there are people who see what's happening along the way and change, because they see the writing on the wall, so to speak, and then there are people who don't change until really the building's on fire, and they have to run from it to whatever someone else has created. So I don't know if that's a slightly cynical approach, but I think that really, I don't see real change happening, certainly in systems, until it is really forced on people. And I think, that we're seeing this with the brain economy. We're seeing people who are out there, because I don't think any of us think we're being really proactive, because the ship has sailed and we're trying to sail it best we can. But I think we see people who will resist it till the end.
Right. Looking at the concrete example of Catalight, which is one of the largest behavioral health networks in the United States. 9 years ago, I think it was, that you started a partnership with one of California's largest health insurers on a value-based care project. And the results are frankly impressive, especially in the area of access to care. So last year, I think 93 of families that you catered for received care within 10 days. So that's compared to the national average in the US of several months to a year. So can you tell us a little bit about how that was possible? How did you manage to achieve those results?
Yes, I think that's a needs must story. So we did it with intentional design. So we were presented with a situation where literally thousands and thousands of people were eligible for services from their health plan on the same day. Legislation passed, and it said everyone now with a diagnosis of autism or who is looking for a diagnosis of autism can receive services through the health plan. So we were a small organization. There wasn't capacity for the treatment network that we needed to build. So we intentionally had to design the network around getting people into care within 10 days, which is a regulatory requirement in California. Unfortunately, not in other states, but it is in California. And so we had to build the capacity for our own infrastructure and the capacity of the network. So we had to go to companies and say, do you want to grow? How would you like to grow? How can we help you grow? We worked with them on things from their clinical acumen to their business acumen, and we grew the network from hundreds of providers to now around 16,000 people who deliver services every day. We have 120 companies in our network, and it's still growing. But I think you see in the US anyway, networks say, we signed everyone up, or health plans say, we signed everyone up to our network, and that's all there is out there. So we've done our job, and we've got as many people as we can into the network. However, in order to really put the patient at the center, as you said earlier, we really have to solve the problem of access.
You solve the problem of access in the context of clearly growing demand, because autism is your main field of activity, and autism numbers have increased, I believe, sixfold since 2000 in the US, and it has to do with many things, higher awareness, but also broader diagnostic criteria. So if the numbers increase sixfold, I mean, the immediate question that comes to mind is how can you cope with such growing demand? And we can probably apply this to many other domains in the neuro space, where you also see this, higher awareness, more and better diagnostic tools translating into, more cases to cater for.
Yes, I think it's definitely happening in the autism space. And it's really about thinking differently. I mean, I'm going with the intentional design, but it's thinking differently about approaching diagnosis, about treatment, and looking at the combination of people and technology. There has to be a shift in how we approach all behavioral health services, actually. This idea of I'm going to have a person sitting in front of me in a room in person is just not something that works for people anymore. Even if it was possible, I think people want different approaches. And I think that we need to think about the idea that one size does not fit all. People say that expression a lot, but in healthcare, and particularly I think in mental health services, behavioral health services, often that's what people are getting, and that is very true of autism care in the US. There is a particular model of care that happens, and it does matter where you are on the spectrum, but that same model of care is delivered. So we need to think very differently about what people need, where they need it, what can technology bring, what can wearables bring, and we're going to need to meet the demand that way, because it's not, we do train people in diagnostic evaluations. We have a postdoc program, but we could do that all day long. We would still never have enough people to diagnose the global population need. So we have to think differently about how we do things.
I'm looking around, by the way, for questions or comments from the audience. Yes, I can see one already. So can you raise your hand and get the microphone? Yes, it's coming.
Hello, Susan. I recently completed my master's in health policy planning and financing, and most of our courses we were talking a lot about value-based care, and especially in terms of pharmaceutical economics and policy. So I'm thinking in terms of the brain economy, what parts of value-based care do you think can be used beyond like early childhood education, but all the investments and everything that's being done, mainly I would see in the US, especially in later adulthood with dementia and Alzheimer's, what aspects of value-based care can be used, especially when we have the problems of privatization versus public insurance and things like that.
So thank you for that question. Value-based care to the brain economy, to me, is essential. High-quality healthcare is an essential driver of brain health. So value-based care, by definition, should bring value to the person receiving the care. Therefore, that should be a positive influence on brain health. So I think the general premise of value-based care must apply to brain health and the brain economy. We need to work out, whatever the age of the person is and whatever we're trying to achieve, we need to work out what would bring value to the person who is receiving the service and to their informal caregivers. And in fact, John Boyd mentioned this earlier, to the healthcare workforce. So when you bring value to the patient at whatever stage they are in their life, you are going to bring value to the informal caregivers that support them and to the healthcare workforce. And I think it's, to me, an essential part of brain economy conversation. Now, I'm not sure if I actually answered your question.
Can you maybe wait for the microphone so that we all can participate in the conversation? Yeah.
Okay, that's the first part, I guess. That I was seeing that the ideologies of value-based care being used in the brain economy is important, especially with healthcare workers. But in terms of how it's actually being implemented with competing interests of insurance companies and healthcare corporations and all of that.
Yes, not particularly well or broadly, I would say in the US. I think it's not easy to implement a value-based care contract. I think people don't always understand the financial models necessary to do it. So I think it's slow adoption, which is, I think, troubling, should be troubling to all of us. And I think that we need to provide practical support to help people make that shift from a fee-for-service model to a value-based care model. They're not going to make it on their own.
Brilliant. Thank you so much. So we have Marco next, and then I think I saw one hand on the back. Yeah, so Marco is next.
Hi. Thank you so much. I'm very curious about value-based and outcomes-based contracts.
You could introduce yourself. Marco.
Oh, sorry, Marco Mowinkel. I am. I wear various hats. President of Tech Tour, mental and brain health programs as well. Curious about the outcome-based contracts. How did you baseline and identify specific outcomes that you would measure, given that it's so subjective? And how do you solve for the attribution problem of the interventions that I presume you offer to the individuals? Because there's a lot of, let's say, multiple factors playing into that outcome. How did you actually practically implement that? How do you baseline for the individual situations? How do you measure that? And how do you then attribute the outcomes to that particular intervention?
Yes, not easily is the answer to that question. I think it's hard to do. So we work with primarily children. So we work with their families, right? Their parents, their caregivers are really important in the story. So we look at things like parent confidence, parent stress levels, and we look at whether the interventions that we have engaged in with them have changed those, in fact, inverted them. And even though we know we're not the only thing that's happening in their lives, we see parents gain confidence in their parenting ability with a child, and their stress level comes down because they feel like outside of a therapy session, they can, well, that was exciting, they can manage whatever happens. And I think we look at what we have well-being scales that we're still working on. We have well-being scales for individuals, for youth, and for families. But again, in value-based care, it's what value are we bringing to that individual and their family, not necessarily what goal are they meeting on a treatment plan. Those two things are very distinct. And so we need to be guided by the patients themselves and their families on what is a good outcome for them. And then there are, you'll see in value-based care, if the treatment generalizes, we do a lot of parent caregiver-led models, you'll see that the length of stay in care is shorter because they feel confident to go out in the world and do what they want to do, which is, to the family, a very positive outcome, and to the payer.
Thank you so much. So I think I saw one hand up in the last row or almost last.
Hi, thank you. I'm Tasha, Venture Fellow at SmartGate VC. I focus on bioelectronic medicine, neurotech verticals, and sometimes you do see these kind of propositions for value-based reimbursement, and it seems actually extremely experimental, and for companies that are trying to commercialize and actually have access to reimbursement. I mean, that's how they're going to survive. I think there's a bit of a barrier just because the model is not very proven.
The value-based care model?
Yeah.
I think there isn't a value-based care model. I think that every situation has to design its own, and that's the opportunity. It's also the challenge. It can be concerning I think you have to deeply understand your budget drivers. You have to understand the connection between what would bring value to someone in a healthcare setting and how that would connect to a budget driver. And it's not, it's an iterative process. You've got to have a good partnership with your funder. You've got to be in it together, so to speak. And I think that's rare. So I would say it's not for the faint-hearted, but it is a huge opportunity for people who are willing to do the work.
I have one question, Susan, about what you claim is also your recipe to success at Catalight, namely that you look at these inflection points as opportunities for innovation. And that's when you get the latest technology, and that's when you get the personalized care in place. So what do you mean exactly by inflection points, and how does one identify an inflection point that can really bring that promise about?
We think about inflection points as being kind of a needs-must point, right? So there was an early inflection point for us where we had an overwhelming number of people needing services and needing those services within 10 days. So we had to think differently and build something that would meet that need. So now we're seeing an inflection point in the opportunity of combining intelligent technologies and thinking about the least intrusive service delivery model. People have talked about least restrictive environment, all kinds of things in the US around care, but not the least intrusive service delivery model. And I think that's where we are now. And I also think another huge inflection point is we now have tools in our hands. Some of them came out of COVID. Like, we do diagnostic evaluations virtually today. Nobody would fund that or thought that was possible prior to COVID. So now we can take that and look at rural service delivery and how do we bring together local community leadership, intelligent technologies, and a network that can deliver services virtually to people literally anywhere in the world.
Susan, I want to end our conversation with a question about the costs, and because we started the summit with health economics, and it is relevant who will foot the bill and how, because what you are proposing is to use the latest R&D, the latest technology, personalized care. You want to provide, and you do provide early access. So that immediately raises the question, how is that fundable? And yet, at Catalight, you managed to reduce the costs last year, I think, by 30%. So how did you achieve that?
We believe at Catalight that value-based care is the only way to reduce the costs. So I think it's, again, as I said, you have to look at what the patient needs, what is a good outcome for them, therefore what is a good outcome for informal caregivers, healthcare workforces, and those gains, that's the value for the people side of it. I shouldn't say the people side of it, because employers, payers, and providers are also people. But if we bring value to the patient and the family around them, we're going to lower the cost of care. I mean, it's that simple. Now, you could say equitable access is a different story. If you actually create the capacity for people to get equitable, timely access, you are initially going to raise the cost, because if half of the people who are eligible for services weren't getting them, and you're able to bridge that gap, then you will see a rise just in the number of people receiving care. But all the typical healthcare metrics, such as length of stay in services, returning to care, all of those things will be reduced and will reduce the cost of care if you work out what brings value to the patient and their caregivers.
Wonderful. Thank you so much, Susan. So, yes, we can transform brain health with value-based care. And encourage everyone to speak to Susan during the break about now the magic recipe for doing so. Thank you so much, Susan, for joining
Thank you.
today. Yeah, thank you. Thank you.